Assalamu alaikum. Welcome everyone on board. So we will start from this question. You have been called to site an epidural for a 32-year-old prima gravida. She is now 3 centimeter dilated with only slow progress and very distressed with each contraction. While you are placing two needle in the epidural space, you see an obvious flow of clear fluid. So PDPH has occurred. So what are different options? You pull out the needle and arrange alternative analgesia. Inject 10 ml of normal saline into subarachnoid space to prevent post-dural puncture headache, and then resite the epidural catheter in another space. Remove the needle and resite the epidural in another space, interspace. Tell the midwife to use 10 ml of epidural mixture for each top-up. Thread the epidural catheter through the punctured dural hole and use it as intrathecal catheter. Make sure only an anesthetic gives every top-up dose. The needle out and call the consultant on call to perform a blood patch to prevent PDPH. I think it should be to thread the, yes. I think it should be to thread the dural catheter. Let's see. Otherwise, if it is not there, then let's see. Because immediately there will be no blood patch. So it is the answer. Inadvertent dural puncture can occur following many procedures, for example, spinal surgery. However, uh, in anesthetic practice, it is usually a consequence of epidural analgesia and anesthesia. Uh, every year, approximately 140,000 laboring women receive an epidural. 1% will suffer a dural puncture. The commonest reported PDP with an increase incidence varying from 60 to 90%. Headache usually develops 12 to 24 hours following dural puncture. PDPH may cause significant morbidity, and mother may be unable to properly care for their newborn and themselves for some time. Puncturing the dura with a 16 gauge results in an obvious CSF flow through the epidural needle. The CSF is warm to touch and test positive to glucose with urine dripstick. Each obstetric unit should have a plan of action for accidental dural tap. At the time the recognized dural puncture, the anesthetic must decide whether to use the catheter for a continuous subarachnoid technique or resite the epidural in another interspace. Whichever decision is made, only the anesthetist should give every dose of local anesthetic top-up. Therefore, STEM D is inappropriate here as gives that. The patient should be informed about the dural puncture and counsel regarding potential complications and further management options. A senior anesthetics colleague, the obstetric registrar, and midwife should also be informed. An operator must ensure everything is documented in the patient's notes. If no PTPH is present during labor, pushing at full dilatation can be encouraged. However, if a headache is present, forceps delivery may be advised. After delivery, remove the catheter as usual. There is little evidence that leaving a subarachnoid catheter in place for 24 hours can reduce PDPH. This is further actions.
لا انا مش عايز.
No headache is present. Post-delivery, do not restrict the patient's mobilization, as immobilization will not prevent the development of PDPH. However, if a PDPH develops, encourage bed rest, regular analgesia, oral fluid, oral caffeine intake, and consider epidural blood patch, which is the gold standard for PDPH. However, if performed within 24 hours of onset of symptoms, there is a failure rate of 70%, which reduces to 4% if performed after 24 hours. And therefore, it is preferable to perform blood patch more than 24 hours after the dural tap occurred. Studies investigating the use of epidural saline as a preventive measure against PDPH failed to reach statistical significance. So that's how the use of sumitriptan and
You
ACT.
run our saline dripping after wet tap to
Yes,
catheter.
yes, Bilal.
Sorry, I'm talking to someone else. Sorry.
Oh, okay. And because your words were also the treatment. Anyways, the use of sumitriptan and ACTH has also
Wait,
previously been
I will
evidence.
get back to
Sure, sure. So actually, the what is the message from this text is that BDPH can occur in this scenario, high incidence. Neural pack should be given after 24 hours, and actually, I also rechecked. It should be given one level below that same level or one level below, and the blood patch. And recently, they have not written here, but actually, neostigmine has also been used for the treatment of this PDPH. The mechanism not known. Anyone knows about it? So this is uh, also being used for as a treatment for post-dural puncture headache after spinal anesthesia. Uh, so the mechanism, exact mechanism, just a second. But as far as I know, the mechanism is not known. So crosses CSF barrier, increase acetylcholine in CSF, inhibits uptake of acetylcholine by choroid plexus. So by increasing the CSF production, that's what it looks like. Early depolarization, cerebral vasoconstriction, late hyperpolarization, increase here. So that's a mechanism. So this is also another thing which you should be knowing about it. Okay, you have been called to an acute medical ward to help manage a man who has become distressed and angry with the medical management of a relative, is now behaving violently toward one of the ward staff. When you arrive, the situation is heated. Security and porter still calls you, and then the on-call psychiatrist, the man is unreasonable and needs to be sedated for safety. I think this is offer the man a dose of oral lorazepam, attempt to assess his capacity and discuss with your consultant, defer immediate management to the security staff and police, give intramuscular lorazepam, haloperidol, give a dose of intramuscular ketamine and transfer to a monitored environment, organize safety, to strain the man and give intramuscular lorazepam. I have no idea about this question. Attempt to assess his capacity and discuss with your consultant. I think this is least likely to be asked in our exams pattern. I will just skip this question because I think this is 24-year-old 60 kg woman has been injured in a house fire. She has sustained 40% thickness lower limb and abdominal burns. Her burns were sustained at 11 p.m. She is intubated in the emergency department for suspected inhalational injury and resuscitated with 2 liters of Ristolide in total. So 2 liters have been given. It's 40%. So at 3 a.m. she is ready for transfer to the regional burns until that unit that is 4 hours away. What is the most appropriate fluid regime during transfer? Colite at yes, compound sodium lactate, 0.9% sodium chloride, colloid solution. I think it should be the crystallide, not the colloids. Let's see. Usually, it should not be the. Actually, I'm sorry. Actually, I was disconnected, I think. Usually, in the first 24 hours, the colloids should not be frequently used because of leaking. Let's see what's the answer here. So it's Renger lactate, it's compound sodium lactate at 700 ml per hour. So how they have calculated? Actually, it is 4 into 60 kg into 6. So actually, it is 9600 ml. It's around 10 liters. Okay, just a second now. Let me see what's the problem in my connection. Can you hear me?
सर हाफ फर्स्ट आवर 8 आवर्स में देना है ना और 16 आवर्स में बाकी का हाफ
Yes.
तो वो हाँ 4800 और उसमें से भी 4 आवर्स गुजर गए हैं और 4 आवर्स रह गए हैं तो फिर 2400 ओवर
Yes.
4
So in the colloid should not be given. And the other questions which they ask about it for referral, more than 2% total body surface area in children or more than 3% in adults, full thickness burn, circumferential burn, unhealed burn for after 2 weeks, any suspicion of of non-accidental injury. Discuss with a burn specialist with an option to opinion to transfer, burn to hand, feet, face, perineum or genitalia, chemical, electrical or friction burns, cold injuries, febrile child with a burn. Intubation of a burn is indicated with stridor, oropharyngeal edema, deep facial or neck burns, GCS less than 8, hypoxia, hypercapnia, or suspicion of inhalational injury. Facial edema can progress rapidly and intubation using a large uncut endotracheal tube should be performed prior to transfer. So these are the other points. It's usually in the burn fluid management, and because the patient later on, if there is inhalational injuries, you have to be intubate the patient early, and the further complication will be AKI, sepsis, DIC. If it is abdominal compartment syndrome can also occur. So the other concerns will be related to it. Airway management without succinylcholine after 24 hours. A previously well 28-year-old man presents to emergency department with a 48-hour history of feeling generally unwell and complains of polyuria and abdominal pain. So it's a 28-year-old with polyuria and abdominal pain. So pH 7.18, acidotic. So most probably it is because PaCO2 is normal, rather low. So it should be the bicarb. So base excess is 8, PO2 is okay. So urea creatinine is slightly high, potassium is high, sodium is okay. So which of the following is the most likely diagnosis? Renal tubular acidosis, severe sepsis, pancreatitis, Addison's disease, diabetic ketoacidosis.
सर इसमें पहले तो एनाइन गैप निकाल लेंगे ना और उससे
Vajiha,
हाई एनाइन
Vajiha, sorry,
यस
talk in English.
ओके सर वी विल फर्स्ट calculate anion gap if
Okay.
it's high with high anion gap or low or normal anion gap then will
What do you
the
think?
cause will be
How is the anion gap?
the sodium plus potassium minus bicarb वो minus chloride
Oh, so it is 142 minus 100 minus. Uh, so I think it is more his high anion gap.
yes sir high acidosis with high anion gap mud piles is the mnemonic
So
mud
anything
piles
here?
here Sir, diabetic ketoacidosis, renal acidosis is with the normal anion gap.
Okay, so they have not mentioned about blood sugar. So it's polyuria with abdominal pain. Let's see what is the answer.
Yes, sir, can be the DK
Okay,
presentation.
so it is first maybe the first presenting of insulin dependent diabetes mellitus in this way. Raise anion gap. So we calculated it is more than 20, I think, and methanol, uremia, DK, propylene glycol, isoniazid, lactic acidosis, ethylene glycol. So abdominal pain and polyuria together with the biochemical picture profile make DK a likely diagnosis. DK is commonly precipitated by infection or non-compliance to insulin therapy. However, an increasing proportion occurs in undiagnosed. So this was a scenario of undiagnosed. Severe sepsis would also cause a raise anion gap, but is unlikely given the history and normal lactate. So there is no other features of sepsis. Normal anion gap in this renal tubular acidosis and Addison's, there is a normal anion gap. So that's it. The in pancreatitis, there may be acidosis. Okay. So one more question and then we will go towards Aisha Beg. A 64-year-old man with a background of hypertension and ischemic heart disease is being managed for septic shock. So it's a scenario of septic shock. The patient has pyelonephritis and gram-negative sepsis that is being treated with sensitive antibiotics. So patient is on antibiotics. The management includes a positive fluid balance of for the last 24.5 liters and noradrenaline infusion in currently administered at zero point 0.8 microgram per kg per minute. Because so you can say that patient is overloaded. Patient is having positive fluid balance and moderate, not a very high dose of norepinephrine, slightly towards higher side, but anyways, mean arterial is still low. The ventilation parameters are deteriorating. FiO2 is 0.6. And now, how is the uh, low cardiac index is also low. Intrathoracic blood volume index, stroke volume resistance is more. Extravascular lung water is also more. So what you will be doing? Um, Actually, in first go, we give fluid, then we add norepinephrine, and then we give, in this scenario, when cardiac index is also low, so I think it should be inotrope. So let's see. Bolus of 500 ml, increase the norepinephrine. Okay, order an urgent transthoracic echo and send cardiac troponins. Commence urgent hemofiltration aiming to reduce pulmonary interstitial fluid. Because here the like it seems overloaded. So either it should be, uh, I think
Sir,
it
his
is.
cardiac index is low, means cardiac output is low.
So
Can
either
be
it
due
is
to
the butamine or echo. Let's see what is the answer. I think either it is either of them, because epinephrine, norepinephrine, or fluid bolus hemofiltration is not. Let's see. Oh, fluid bolus cardiac output monitoring is increasingly more important in the management of hemodynamically unstable patient on the ICU. There are many different options available, including pulmonary artery catheter, minimal invasive measurements, including pulse contour analysis or esophageal Doppler. how it is. Anyways, the most popular currently is minimal invasive technique requiring arterial access for pulse contour or pulse power analysis. Two different types exist: transpulmonary dilution perf for calibration with LIDCO and PICO.
ऐसा निकलने लगा.
So, no calibration is performed and therefore no central line is required. Analysis of arterial waveform is conducted by a proprietary formula, which are more convenient but less accurate. It's flow track Vigilio. So there are two different types, three different types. One is this Vigilio, and this Pico or Lidco. The readings above are from a minimal invasive device using transpulmonary dilution curve analysis, which offer the advantage of accuracy comparable to a pulmonary artery catheter, in addition to continuous waveform analysis. Cold lithium injectate is injected through the central line, and the temperature of lithium concentration is measured at an arterial line placed in a large artery, femoral or axillary. Injectate mixed with the following before reaching the arterial line. From analysis of dilution curve, one can calculate cardiac output, detection of volumes, global end diastolic volume. The sum of all end diastolic volumes, intrathoracic blood volume is the global end diastolic volume in addition to the pulmonary blood volume. Extra lung water, extravascular lung water. Continuous cardiac output monitoring is displayed after the calculation of aortic compliance, derived from blood pressure and blood flow recordings simultaneously. So this, with this formula they calculate is why they are giving fluid in this scenario. Let's the most appropriate intervention given the values above is more intravenous volume administration, monitoring for an improvement in the cardiovascular status, including a higher
सर थोड़ा
minimal
ऊपर
pressure.
करके ऊपर थोड़ा सा it is written above sir the letter sir this there it is written the patient describe this one sir.
So what do you think the reason? You see, because here in this scenario, we have cardiac index is low. Okay, the cardiac index is low, and the blood volume, intrathoracic blood volume index is actually low, but SVR is normal and extravascular lung water index is also high.
Sir SVR is high sir.
SVR is high. SVR is high. So SVR is not a problem. So with this index, they are saying intrathoracic blood volume index. They are saying that the patient needs more fluid. This information, because
Sir, with low cardiac output and in high SVR means that inotropes are there
because my
functioning well,
because
and uh, it, it's not the it's the
your sound is
need
breaking, Wajiha. The patient described above has a low cardiac output, reduced preload, intrathoracic blood volume index. Okay, so this is a indication of preload and as overconstricted. So extravascular
output
lung
in
water index is
when
raised
high SVR.
and the ventilation is deteriorating, muddying the management waters. Effort to exclude an ischemic cause of shock is warranted, and commencing hemofiltration is important for modifying fluid balance once the inflammatory cascade has settled. But both will help little with the hemodynamic compromise in the immediate term. The most appropriate intervention is this one. So the patient described has low cardiac output with low preload. Actually, I was mixed up with this one. The extra lung water index was more. So intrathoracic
Sir,
blood volume.
what does this extra lung water indicates? Inflammation.
Extravascular lung water. Actually,
So this indicates that there is element of inflammation, like increased permeability.
yes,
So they are that's why they are prescribing that it's the inflammatory phase. Once it's over, then we'll start hemofiltration.
yes. Actually, we need to know about the monitoring of this cardiac output system because this is mainly on the reading. So I have not prepared this topic. So unfortunately, I cannot say much about it. Uh, I will try to cover this topic later on because it needs someone or I need to read about the full fledged different types of cardiac output monitoring and their parameters. I just know the basic concept that like how it works, but not that much detail on which they are asking. So here the bottom line in this scenario is there is a patient has septic shock on antibiotics, giving a good amount of fluid, vasoconstriction is there, blood pressure is still not there. So I was just thinking because patient has positive fluid balance, but according to this intrathoracic blood volume index, actually it's low. So that's why they are asking to give more fluid. In my opinion, this should be the answer, the butamine. So we will have few points from this. I think one more question, and then we will come here. A 17-year-old man admitted to the critical care unit having ingested 11 gram of paracetamol. An acetylcysteine infusion has been started and bloods are awaited. Blood pressure is low following 1 liter of Hartmann solution. The heart rate is tachycardic, agitated, and full neurological examination is difficult. 100% oxygen, SpO2 is 92% with tachypneic. So FiO2 is 100, pH severe acidosis, PaCO2 because patient is hyperventilating. PO2 is good. Acidosis, lactate is high lactate. Intervention in his management would be CVP and start norepinephrine, intubate and ventilation, urgent transfer to a liver specialist, ICU, CT head, placement of a urinary catheter. Intubation and ventilation, the patient is uh, this is a delayed presentation of paracetamol overdose with evidence consistent with fulminant liver failure requiring urgent management. Paracetamol overdose is leading cause of acute fulminant liver disease. 90% of ingested is metabolized by the liver. In non-toxic doses, predominant metabolic pathway is via glucuronidation and sulfation, with less than 10% metabolized by an alternative pathway via cytochrome P450 to a toxic metabolite, this NAPKI. In health, NAPKI is inactivated by glutathione. So when this pathway is overwhelmed, this is damaging the liver. This patient has taken a toxic dose of paracetamol with probably represent 150 milligram per kg. So the patient took 11 gram. This is 11 gram. This is too high. Usual pathway of glucuronidation and sulfation are exhausted. P450 represent an increased proportion of metabolism once glutathione reserves are depleted. Unconjugated NAPQ exerts toxic effects through hepatocellular damage. In this patient, the delayed presentation has compounded this damage. A staggered overdose may also have a similar presentation. The management principles of a paracetamol overdose, like airway breathing circulation, and with specific management of this like this N-acetylcysteine, and there is this King's College classification, College criteria for acute liver failure. According to that, they will go towards the liver transplant. So, patient is tachypnic due to profound underlying metabolic acidosis. He is likely to tire from the work of breathing, and his underlying problems are difficult to assess and manage with the agitation. So, intubation and ventilation is the next most appropriate. Fulminant liver disease is consistent with a high cardiac output and low systemic vascular resistance, and may require vasopressor support. However, at the present, he is not adequately fluid resuscitated and unlikely to tolerate an awake insertion of a central line. Hence, option A may be appropriate on in his. So, we have to do all the things. We have to transfer CT. I'm not sure about CT, but let's see. Unfortunately, he has presented beyond the window for gastric decontamination with activated charcoal. How many hours have gone? 18 hours. So activated charcoal, I think up to 12 hours, Zishan.
Yes, sir. I think
Actually,
so. It's up to 12
actually for
hours.
this acetylcysteine, there is a normogram. So we give the N-acetylcysteine according to the normogram, according to the hours elapsed and how much are the blood levels. Okay, so is true for activated charcoal. There is a limited. This should be considered within 2 hours of ingestion. It's not 12. I thought it was 12 hours, if I'm not wrong. Anyways, they have written 2 hours, or where a staggered dose is suspected. What is staggered dose?
I
Staggered
think it is
overdose.
50, uh,
Anyways,
50 mg per kg.
so I think this is too low, too high dose. This is staggered. What is the meaning of staggered? He has correctly been started empirically and indicated by the severity of his overdose.
So staggered is when if a bolus at one constant of time, it is given on intervals of times.
Again, please.
So when the total dose is not given at a time, at one time,
Okay,
it
so
is given on
gradually,
different.
one by one, staggered. Okay, I understand. So I think not at one time, gradually, over a period of time. Okay, he has correctly been empirically N-acetylcysteine increases glutathione reserves and enhance conjugation with NAPK. The dose is 150 milligram per kg loading over 15 minutes, followed by 50 milligram per kg over the next 4 hours and 100 milligram per kg over the subsequent 16 hours. So you can just memorize the dose. 150 milligram loading over 50 minutes, 15 minutes, then 50 milligram per kg over 4 hours, and then 100 milligram per kg over 16 hours. So that's like 150 milligram per kg dose, loading dose, 50 milligram per kg over 4 hours, and then 100 milligram over 16 hours. Where a non-toxic dose of paracetamol is suspected, waiting for 4 hours post-ingestion paracetamol level is appropriate, comparing with the new single-line paracetamol treatment normogram. The patient clearly needs to be discussed with the local liver transplant specialist intensive care. So that's what I was telling, King's College hospital criteria. So in any MCQ, they can make an MCQ on this scenario as well. They will put something and they will ask you about. So you should be knowing what is the criteria for it. Prothrombin time for INR more than 6.5. Creatinine is more than, I think, 88 is 1. So around 3, more than 3, 3.5. Grade 3 or above encephalopathy. He will require a urinary catheter to measure urine output. The cause of his for his agitation is most likely is acidosis and possible encephalopathy. If the circumstances around his overdose raise suspicion of trauma or collapse, a CT head should be considered. However, at present, it's not immediate action. If the circumstances around his overdose raise suspicion of trauma or collapse. So actually, the knowledge information through this MCQ, what occurs in paracetamol poisoning, that usually the metabolic pathway which is metabolizing it is overwhelmed, and then the extra NAPKI is damaging the liver. Okay. Here they have not written about the liver enzymes. So there are something which you can expand. Here, what the information here is, patient is tachypnic and having requiring high FiO2, low, like blood pressure is on the lower side, and like there is severe acidosis. So patient needs to have CVP, norepinephrine, and transfer to liver transplant. CT may be needed, urinary catheter, all needed. But the first thing in this scenario will be intubation and ventilation. So they can make question about this scenario. Okay. Okay, so actually, we were doing some question about this PDPH. So actually, differential diagnosis of headache should be there. Cortical vein thrombosis or any other serious problem should be ruled out uh, before, if because if serious problems are not there, then you will be going towards the traditional, the what you say, supportive management. Bed rest actually is not recommended. Maybe the patient, if the patient is having headache, patient can lie flat for some time, and as soon as subside, the normal activity should be resumed. It should not be a strict bed rest, because strict bed rest will cause chances of DVT. That's what I remember. Okay. And caffeine, role of caffeine, role of blood patch. We discussed about yesterday, we had a confusion that we should give blood patch at higher level or lower level. So actually it is at the level or lower level. Okay. Reason I couldn't find, but that's one thing I have. There is a role of neostigmine also. How I have not used it, but neostigmine is also an option. Sumitriptan is given for prevention. Beta blockers are also given for management. Otherwise, the normal medications like paracetamol or NSAIDs, they are given. Okay. And you should know, because in even in the talks they ask about the chances, the percentage. So you should be knowing the incidence of PDPH according to the needle size. Even I remember this question. This there was, we chalked out when we were preparing. So there are specific incidents with the specific needle size. So you should be knowing about it. So okay, PDPH is associated with lateral gaze problem C6. I don't know what is the question in it. If a patient complains of nausea, vomiting, and headache, to involve neurosurgeon, as I told you, there's some cranial pathology should be ruled out. Uh, in this scenario, 25-year-old female, full-term pregnant, underwent lower 20 kh needle. Did she develop PDPH? One of the following is not a feature of PDPH. Occurs in frontal or occipital, usually self-limiting in nature, aggravates on sitting, accompanied by tinnitus or photophobia. It's not unilateral. Yes, phenolpalatine block is a less invasive alternative to an epidural blood patch. Yes, this is also one of the option. It's not unilateral. So the feature actually, if you want to prepare, if for example, even this book, you want to prepare, you should go here and you should read the articles for that topic. So as I told you, that you can have different articles for it. Like in, for example, if I want to read it, I will read like this: pathogenesis and anatomy. How it is unclear but thought to be caused by CSF leakage into the epidural space via tear in the dura. So this is enough. CSF loss leads to a reduction in intracranial pressure and downward traction on pain-sensitive intracranial structures, including veins, meninges, and cranial nerves, resulting in a headache that is classically worse in upright position. The fall intracranial pressure may also cause compensatory cerebrovascular venodilation, and this may contribute to the development of headache. So if someone asks you, you can just explain in this way. CSF is leakage, intracranial pressure reduced, and then there is downward traction, okay, pain sensitive intracranial structures, so and then compensatory vasodilatation. So that's what occurs. So differential diagnosis, meningitis, encephalitis, okay, dehydration, caffeine withdrawal, all these, migraine, cortical vein thrombosis, okay, cerebral infarction, so that's why it said that if these things are ruled out, there is nothing like that, then it becomes a self-limiting thing, okay. But first of all, the question which was here, this question, so this was according to the differential diagnosis here, okay. So if you study in that way, then these books will help you. But if you just want to cram the answer, unfortunately, and for the people who are preparing for oral part, they can ask you in the similar way. They will ask you what is the differential diagnosis of PDPH. You should be knowing about some of the space. You should just know what are the vascular causes, what are the other causes. Okay. Even preeclampsia can be there. Patient does not have headache before, but now, so some clinical features will be matching. So there will be headache alongside there may be high blood pressure. Maybe like you can measure the proteins, and then you will come to know. Okay. So you can see that PDP, preeclampsia, tension headache, benign. So you should be knowing about it. So okay, history and examination should be performed, taking timing of headache. By the way, in practically, I have seen immediate development of headache. Okay, I don't know. They always say like this, but because some anesthetists will say, I have done hundreds of epidural, I have never done a dural puncture. They are all lying. I can guarantee that there will be no anesthetist in the world who can claim that I have never done a dural puncture. Rather, the day you will do the dural puncture, you will come to know how what is epidural. So if you have not done it up till now, you still don't know what epidural is. So in my personal experience, I have seen even immediate headache. Even during the operation theater, I have seen patient have, I don't know the reason for it, maybe but theoretically, because this can, if it is massive leak, it can, and if there are other factors. So now if patient is too much dehydrated, it can develop early. But according to the theory, what they say, that it develop after 12 to 24 hours. So in the MCQ, you should focus on that thing, but I'm just telling you this is a practical thing. Okay. So they can ask you question about which needles will prevent. So is PDPH is more likely with a large gauge cutting tip needle, or after multiple attempts at spinal block, which might result in a number of dural tears, pepper potting of the dura, increasing the chance of a CSF leak. The cardinal feature headaches as are headache that develops within 7 days of dural puncture and disappears within 14 days. However, PDPH has been reported to occur later and continue for longer than usual times. So headache is often fronto-occipital. So that was the MCQ here. Most headache do not develop immediately after dural puncture, but 24, 12 to 40, different words you will find in different sources. After the procedure, with 90% of headache presenting within 3 days. The headache is worse in upright position and eases with supine. Pressure over the abdomen with the woman in upright position may give transient relief to the headache by raising intracranial pressure, secondary to a rise in abdominal. This is what is called a pressure over the abdomen with with the woman in upright position may give a transient relief by raising ICP, secondary to a rise in. So pressing the abdomen will decrease the pain. Associated symptom that may present neck stiffness, photophobia, tinnitus, visual disturbance, and cranial nerve palsies. Okay. The skin over the epidural or spinal puncture site should be inspected for CSF leak, inflammation, and tenderness. Basal observation of heart rate, blood pressure, and temperature should be recorded. So that is because if they are, the neck stiffness is there and femur is there, so maybe some other. Okay. MRI may demonstrate diffuse dural enhancement and brain descent. maybe there. Okay. So spinal needles, these are Quincke needles and Whitaker. Okay, and one, because it's here right now, so I will just I would like to tell that whenever we puncture, we should go in the one like you should make the cutting side on one cutting edge on one side rather than going straight, because if you are going straight, it will cause more damage. Okay, and when you are injecting, you should inject in the upward direction. So that's something you should be knowing. Epidural can be inserted using a loss of resistance with air or saline. Usually, if you are using saline, constant is better. Okay. Another thing which you should be knowing, that if you are doing in paramedian, the chances of the incidence is relatively less. Okay, and conservative management, pharmacological, caffeine, vasoconstrictor. They will ask what is the mechanism for caffeine. So it's causing cerebral vasoconstriction. So if you are reading this whole article, you don't need to waste. You don't need to read everything. Okay, so you can just get the information. You see in high dose, you will find how to scan this article. Okay, what is the role of ACTH? So a mechanism includes CSF retention through increased mineralocorticoid mediated sodium reabsorption. Okay, a direct analgesic effect via its glucocorticoid activity. So this is the mechanism. So that's, they will ask you if we are asking you if you can answer few words about it. Okay, this serotonin agonist, sumatriptan, gabapentin, desmopressin, theophylline, hydrocortisone, blood patch. We discussed about few words about blood patch. Volumes 2 to 60 ml have been used. Optimal volume is 10 to 20 ml. If the patient report discomfort in the back during the procedure, the injection should be stopped. That's how we do under the sterile condition. And now we know. Yesterday we had a confusion that we should do it one level below or at the level. Backache, neckache, transient bradycardia. Prophylactic PDPH, sorry, blood patch is not recommended. Epidural fluids. A number of fluid both have been used in epidural space. Increase the CSF pressure and provide temporary relief. Long-term relief is less likely. Epidural morphine. Yes, very good article. Anesthesia tutorial of the week 2021. Yes, you actually, so you can, so the bottom line for today's discussion is that PDPH is a frequently asked question. So you should be knowing the differential diagnosis, how to prevent, how to manage, and different strategies you should be knowing about it. Okay. So the other questions which we discussed today, one was this undiagnosed decay, burn fluid. This is a previously I skipped this question. This is psychiatric patient. And then what to do if there is dura is puncture. The other approach I couldn't discuss here, but if for example you don't want to do this catheter, what other option? Even this is a practical answer. You will immediately lie the patient flat, and you can try. You can start some fluid. You can start giving some fluid, and if you want to try, you will do it at a higher level. That's what I know. You will do it at a high level, and you will do it in lateral position. That's what is here. So, and then so we had these question, that this question actually need a lot of knowledge about the use of these cardiac output monitors. Unfortunately, this is a topic which I have read once in the exam, even not much. So if you want to know about it, I can show you the fluid management on the monitoring. You should be knowing how these different cardiac output monitors work. Okay. So then you will be able to answer in a better way. But generally, if there will be extra lung water, it means the patient is overloaded, and stroke volume and this systemic vascular resistance and cardiac index These are all combination of the things by which you will decide whether you want to give fluid, whether you want to increase vasopressors, whether you want to give inotropes. So according to this thing, because practically when we do, we don't go in too much details of the theoretical things. So this is why I couldn't help you in this. So this was on paracetamol poisoning. We discussed about it. So now you can expand your knowledge with that. What are the signs, symptoms of liver failure? What are signs, symptoms of, what are causes of acute liver failure? Okay, different management strategies. So conservative management, encephalopathy management. Okay, so general ICU care. So all of the things will be coming here, and so we will continue inshallah. Actually, extracting the points. So tomorrow, inshallah, we will discuss about these DAS. So please do read about it. So these questions, I think some questions are about. So for that, you should be,
I have
yes,
a question, sir. Last पे एक question करना चाहूँगा, sir.
yes.
Sir, मुझे जब it was my IMM OSPE exam. In that
Noon,
OSPE,
please talk in English. Talk in English, please.
uh, so I have when I had sir my IMM intermediate exam, sir. In that
Okay.
exam on OSPE station, there was they asked me a question that while a nursing mother who developed PDPH, which position is safe? Either supine or the lateral one, sir.
Nursing mother, I think, no, in which position patient should nurse?
Yes, sir. Yes, sir. What they asked. This was the question.
I think it should be
I said
lateral.
lateral. Sir,
But
मैंने भी same answer.
Zishan, what do you
But ये
think?
this is the question. If you have any
Zishan,
idea
what do
regarding
you
this.
think? The question he is
Sir,
asking is,
I think it would be very impossible to nurse in supine position.
yes.
Baby could aspirate in nurse position. Baby
By
head
the
should
way,
be elevated.
no, Noon, on a lighter note, because you are still not married, so you don't know how a mother nurse a patient after delivery. So that needs a practical experience as well. Okay. So I did.
Sir, I am married, but I don't have kids right now, sir. But I am married, sir.
Okay. Anyways, thank you very much.
Okay, sir. Thank you, sir. Thank you,
So
sir.
please
Thank you so
read
much, sir.
about this, the difficult airway society algorithm. So we will discuss about it tomorrow. Okay. Bye bye. Thanks all of you
Thank you,
for
sir.
your presence. Bye bye. Salam.